Okay, good evening, everyone, and thank you so much for joining us this evening for our Ask the Expert special edition on anticoagulation. Before we get started, I just had a few brief announcements. To minimize interruptions, everybody but the panelist is muted, so please don't unmute yourself. You can submit any questions you have through the questions function. It's on the control panel that should be popping up on your screen under the list. Says audio, webcam, then questions. You can enter any of those in there. And just so you know, this program is being recorded and we will post it on the NATF website in 24 to 48 hours so you guys can access that recording. So I am thrilled to introduce to you our panel of experts for this evening. We are delighted to be joined by not just one, but three pharmacists who all specialize in anticoagulation. So if you guys would all like to introduce yourself, we can go ahead and start with Andrea.
Hi everyone, my name is Andrea Lewin. I'm a pharmacist that works out of the Brigham and Women's Anticoagulation Management Clinic. I've been there since 2009. I graduated from Massachusetts College of Pharmacy in Boston, and I've really been in Boston since, been in anticoagulation since I've graduated. So thank you for having me.
Thank you. Beata?
Hi, good evening, everyone. My name is Beata Rucinski. I'm a clinical pharmacist at the Anticoagulation Clinic at Dana-Farber. Currently, I've worked at Anticoagulation Clinic at another hospital and also been a pharmacist for a little bit longer and have experience as an inpatient anticoagulation pharmacist also. Thank you.
And Themio?
Good evening, everyone. My name is Themio Papadopoulos. I graduated in 2016 from Northeastern University in Boston. I did a residency also at Northeastern, specializing in academia, geriatrics, and ambulatory care with a specialization in anticoagulation management. And I've been at the Brigham Women's Hospital Anticoag Management Services since I graduated from the residency in 2017. Thrilled to be here tonight and happy to answer whatever intricate questions you guys might have.
All right, great. Thank you, guys. And I'm Catherine Mickelson. I'm the Executive Director of NATF, and I will be moderating the discussion this evening. So many of you submitted questions in advance of our program, and we really realized that those questions were concentrated into three main topics, and those were anticoagulation and COVID-19, anticoagulation before and after surgery, particularly in the setting of a total hip replacement or knee replacement surgery, and then just general anticoagulation questions. So we're going to start by addressing the questions that we got in advance. Like I said, if you do have questions that come up during the program, please feel free to enter those into the questions box on the control panel. I will do my best to answer all the questions that are submitted using that function, but I do apologize if time prohibits us from getting to them. So in the event that your question does not get answered, you can email it to us at events@natfonline.org, and we'll go ahead and try and get an answer for you. So we have a lot of ground to cover this evening. So let's go ahead and get started. We will start with a topic that's still top of mind for a lot of people, and that's COVID-19. So one question that came in is, if you have a history of blood clots, are you more susceptible to COVID? And if so, does being on an anticoagulant offer any sort of protection? So I don't know if...
Yeah, I can take that one.
Go ahead.
So I guess to address the root of that question, so if you are susceptible to blood clots, you have a history of blood clots and you're currently on anticoagulation, does that put you at risk to contracting COVID-19? So the root of that would be the contraction of COVID-19. So there's really no susceptibility or link if you're prone to blood clots. It doesn't put you at a higher risk for getting COVID or becoming infected with COVID. Now, if the question or the concern is more related to if you get COVID, are you at a higher risk for blood clots? I would say that it's a similar risk as if you had any other infection, cold, flu, anything like that, or you were hospitalized. You're at an inflammatory risk, which puts you at a higher susceptibility for a blood clot to form in that state. So we see certain patients that kind of contract COVID that have been in the ICU setting. That puts you baseline at a higher risk for developing a blood clot. However, if you are currently on an anticoagulant medication at a therapeutic dose, that greatly minimizes your risk of contracting or of developing a blood clot, regardless of whether you have COVID, whether you have influenza, whether you have pneumonia, any type of an inflammatory type condition related to those. But the bottom line of that question would be, if you're susceptible for blood clots, it doesn't put you at any higher or lower risk of contracting COVID, like something if you had an immune condition like diabetes, or you had a heart problem at baseline, where we've seen those patients, if they get COVID, they have a more severe infection, but not necessarily will you be prone to getting COVID if you've had a blood clot in the past.
Themio, I think those are a lot of really great points. One thing I'd like to also add is that if you were to catch COVID and you are on an anticoagulant, it's extremely important that you continue to take your anticoagulant. It's not going to heighten the risk of you getting a blood clot, but it's important that you not discontinue your blood thinner or your anticoagulant in the context of having COVID-19.
I would like to add in that whole question, the important is to just get the immunization for COVID while being on anticoagulant. It's important to continue, not to stop the anticoagulation before getting the immunization regardless. And it's just so the person that is immunizing us need to know that we are on anticoagulant, and being careful, having the gauge needle that is smaller, also to hold the arm for 2 to 5 minutes to prevent bleeding. So the whole, I think that would close the question of the anticoagulation, the COVID-19, and I just wanted to remind people to have the immunization.
Yeah, that's great. And that ties in neatly to the next question. But just to kind of summarize, the first question is basically being on an anticoagulant or having a history of blood clots does not put you at a higher risk of contracting COVID. Being on an anticoagulant does offer some protection from developing a blood clot, regardless of being diagnosed with COVID or not. And that if you do get COVID, you want to stay on your anticoagulant. And I'm assuming if you're hospitalized, let your healthcare providers know that you're on an anticoagulant so they can continue that. And then Beata, just to make sure that you get your vaccine. And if you do get your vaccine, or when you get your vaccine, just make sure that they know that you're on an anticoagulant so they can take good care of you. So regarding the COVID-19 vaccine, are there any medical conditions that would warrant prophylactic anticoagulation before receiving the vaccine?
There's no anticoagulation medication, meaning Warfarin, or those newer drugs that don't require monitoring, so Xarelto, Eliquis, Pradaxa, Savasa. You do not need to take any type of prophylactic dose of one of those medicines if you are going to be getting the COVID vaccine.
Yeah, to add, the COVID vaccine doesn't increase your risk for developing a blood clot in any manner. So that wouldn't need to require prophylaxis, as a different condition that would put you at risk for a blood clot might, so that there's no kind of correlation between the two, I guess, to put it like that.
I may add that I think it could be the question for Johnson & Johnson vaccine that patients have developed a clot. There were females, and there was over 7 million vaccinations. It was a very rare happening, and it's not recommended it is not preventable from patients getting vaccines. So patients should be vaccinated regardless and should not be afraid.
Okay, great. So that kind of closes out our section on COVID. Only getting 2 questions on COVID. Hopefully that means that we're kind of seeing the light at the end of the tunnel here. So now we're going to move on to questions about anticoagulation and surgery. So we'll start with a patient wrote in, they have a history of pulmonary embolism as well as a genetic factor 2 mutation, and they need to get a knee replacement. So what should they do about their anticoagulation?
I actually think this is a really common situation. A patient with a history of a blood clot, or maybe a history of multiple blood clots that also has a hypercoagulable state. In this case, the patient has a prothrombin gene mutation, and you have to undergo surgery. Well, at some point along the line, everybody's probably going to need a surgery for various reasons at some point in their life. So being on an anticoagulant, one thing that I think we have to factor in is, when were these history of your blood clots? Was it something that was recent? Was it something that was a long time ago, 20 plus years ago, and you've not had any reoccurring events since? So I think the timing of when you had these recurrent blood clots would definitely play a factor as far as how we would manage you in the perioperative setting. The other question is, you've got the prothrombin gene mutation. So that would inherently put you at a little bit of a higher risk of blood clots than the average population itself. So kind of pulling those bits of information and putting them together, we can kind of take a case-based approach, very specific into what the patient needs. So if this is somebody who had a blood clot 20 plus years ago, and we know has prothrombin gene mutation, you could say maybe we could take a less aggressive approach with anticoagulation. We definitely want to stop it for 5, the Warfarin, stop it for 5 days, before the procedure. And I think what would cause me to want to bridge somebody with a low molecular weight heparin injection like Lovenox would be if their history of blood clots has happened very recently. Was it within, the past 3 or 6 months? That certainly would be a trigger for me that we need to employ other measures besides just stopping the warfarin. So the history of the blood clot is definitely something important to consider, and the fact that you have a thrombophilia itself is something important to consider. So for somebody like that, I would say typically if it's warfarin we're talking, we'd stop it for 5 days prior. If we are worried about the risk of clotting, meaning that the blood clots have happened recently, and knowing that you have the prothrombin gene mutation, we definitely want to bridge you with a low molecular weight heparin for a couple days leading up to the procedure, and we would make sure to stop that with enough time that it wears out of your body going into the surgery, so that you're not at an extra risk of bleeding for that surgery. But I think that's a great question, and definitely something, regardless of who you are as a patient, anytime you're having a major surgery, we're going to be doing, whether that be your anticoag service or the surgeon that's doing the procedure, they will specifically do your risk of having a blood clot versus your risk of bleeding, and they'll make sure that that anticoag plan is tailored and very specific to your needs.
Now, what about if you have not had a blood clot, but you have a family member, like a parent or a close relative that's had a blood clot? Is that something that's important to mention when undergoing surgery?
So I would say that that would be important to mention to your doctor in general, regardless of whether you've had surgery or not. It's not something that is routinely checked, like a genetic test, if you haven't had a history of a blood clot yourself. The guidelines don't recommend actively testing the genetics as far as whether you have um, a coagulable state or genetic predisposition for clotting, just because it's not going to change what we're doing for you regarding the procedure. So if you have a family history, let's say a parent had a blood clot in the past, it's not something we would routinely run a blood test for, because if we found that you had a similar kind of predisposition to clotting, but you haven't had a clot, it still doesn't warrant anticoagulation unless you've had that first event, because we wouldn't want to increase your risk of bleeding without knowing kind of the fact that you've had a clot in the past. Obviously, depending on the type of clotting disorder that your parent had, if there was one, or if it was just something that was what we call a provoked clot because they had a surgery or a long plane or train ride and they were sitting for numerous hours and a clot developed. But I would say, to kind of summarize Andrea's great response to the kind of perioperative management of anticoagulation, I'd like to echo it's super important, if anyone on anticoagulation is getting any type of surgery or procedure in general, to make sure the proceduralist or the surgeon is aware that you're on an anticoagulant, and also your doctor or anticoagulation manager is aware that that procedure is happening at least a week or two in advance, so that a plan can be put in place, so that number one, the procedure doesn't have to be canceled, and number two, so that everyone's aware you're on a blood thinner or an anticoagulant, to make sure you're not at a risk for bleeding around that procedure. And again, to summarize, it's stepwise how we do it. So if the procedure has a risk of bleed, that's how we decide whether or not the patient needs to come off of the anticoagulation as step one. And then step two, if the answer was yes, the patient needs to come off, are you at risk for thromboembolism or blood clot while off of anticoagulation? If the answer is yes for that and the risk is high enough, then we'll think of whether or not to use an injectable agent to kind of bridge between the time you're off of your anticoagulation and the procedure, to make sure that we're keeping you as safe as possible. But the whole time there's that check and balance of the bleeding versus the clotting, and it's so patient specific and so procedure specific, where there can't really be a blanket answer for any particular case. It comes down to the patient's risks and the procedure in general.
Mhm. And we just got a question that came in. Is it easier or less risky to manage the risk of clotting and bleeding if you're on a Dowak versus Warfarin around major surgery?
I would say overall, as a very blanket statement, it's easier for kind of both parties involved, just because the way that the DOACs or the direct oral anticoagulants, the newer medications, Xarelto, Pradaxa, Savesa, and Eliquis, the way that they work, they have a very quick onset of action. So how quickly they start working and making you therapeutic and safe after you take them. And also they have a very quick offset. So how quickly they leave the body and they no longer have that effect of the anticoagulation in your blood. So around the procedure, usually depending on your renal function, how your kidneys are working, dependent on your age and things of that nature, we usually have to stop the DOACs 1 to 2, sometimes 3 days before the procedure. And there's usually no need to use an injectable bridging agent, because of the time between you stop the medication and the time of the procedure can be tailored so short because of how quickly it wears off, versus with Warfarin, we have to wait that 5 days to let your INR trend down to baseline of 1.0 before the procedure, to make sure the clotting factors are regenerated in the blood and things like that. So as a rule of thumb, it's generally easier with the DOACs, just because they wear off very quickly. And then after the procedure, as long as there's no risk for bleeding after the procedure and the doctor says you can resume anticoagulation, right when you take it, within 4 to 6, 8-ish hours, it's already working again. Whereas with the warfarin, it takes about 3 to 5 to 7-ish days to get back to therapeutic levels with your INR. So it's a lot quicker and streamlined with the DOACs. But again, there are those very specific cases where we cannot use a DOAC or it's just not affordable. So that's why having an anticoagulation management service or a doctor that's working close with your anticoagulation should be aware of any procedures coming up so that they can tailor a plan that's safest and most effective for you.
I just wanted to add, sorry, I just wanted to add that right now, we can also be patients being on DOACs, and if there is a question, even though after holding for 2 days, and then, for instance, there is going to be a procedure that needs neuraxial intervention, we can also measure the level of the DOAC in patient system to make this even safer, just as an option for patients being on the DOAC. It's important.
And Beata, I know you work a lot with, because you're Dana-Farber, patients who have cancer. Are there any special considerations for those patients when undergoing surgery as part of their treatment?
We are also the same peri-procedure anticoagulation guidelines are the same for us, the other patients. A surgery is a surgery, so we would also recommend to hold, if patient is on warfarin, 5 days before. We will accordingly, if they need to be bridged based on their event of DVT or PE, we will bridge them, and we also will consult the appropriate physicians, the proceduralists that would do the surgery, if they are in agreement with the peri-procedure anticoagulation. And for DOAC patients, we will also stop 48 hours, sometimes 3 days, based on the procedure and kidney function. So that, I think, is the same how we approach patients prior to surgeries.
All right, great. So another question that we got about this is, are there surgeons who specialize in patients with a history of blood clots and who are on anticoagulation? But it seems like from what you guys have said that you really just want to make sure that it's either a surgeon who's very familiar with patients who have a history of blood clots and anticoagulation, or that they have a very reliable anticoagulation service that they can direct those patients to manage their anticoagulation around surgery.
I would like to add that when patients, so we manage peri-procedure anticoagulation, pre-procedure anticoagulation. Once patients are admitted and in the hospital, the anticoagulation is in the hands of surgeons and the team that manages the patients, and hospitals have the plethora of anticoagulation guidelines to use on those patients. So sometimes something goes not as planned and patient has to stay longer in the hospital. They won't be then following our direction to restart the anticoagulation and so on. Then the team will take care of the inpatient anticoagulation.
Okay, great. Well, those are our questions around surgery that we got, and that was really thorough and very helpful, so thank you. So now we're going to move into some of the general anticoagulation questions that we got. And one question that came over the chat that I think is just kind of an interesting question to start, so everybody has kind of like a baseline about the price of the DOACs versus Warfarin. And can one of you please speak to the cost of the DOACs and maybe the benefits of, taking on that extra cost versus Warfarin? So if patients are making any sort of decision as you answer these other questions, they can take that into context as well.
Yeah, so I can speak to that. So I would say with the DOAC medications, again, these newer agents, Xarelto, Eliquis, Savaysa, Pradaxa, they're newer agents, and inherently, since they're still brand name, the prices for them are much more astronomically higher than Warfarin, which is a much older agent. And again, not necessarily saying because it's older, it's not as good or it's worse. So these medications were studied against Warfarin as the standard, and they were found to be non-inferior, so not worse than warfarin, just as good. And if we actually look into the studies, something that I like to tell my patients is when they compared the group that were on these DOACs, the newer agents, to the warfarin, the standard of care, the patients that were on warfarin in these trials were in their range about 60% of the time or so. So I know at Brigham Anticoag Management Services, our patients are generally about 70% of the time in their range. They do very well. So when there's that question between whether we should kind of switch over or whether it's better or worse to be on warfarin, it's really just as good to be on the DOAC as it is warfarin. Now, when we take the financial part of that into the equation, the DOACs are much more expensive. They're about $500 a month on average for the cash price of it. Now, depending on your insurance, depending on a lot of different factors related to your insurance, it might be a co-payment of $100 a month. It might be $10 a month. There might be a deductible involved. Each patient's insurance are extremely specific, and depending on the time of the year, depending on whether you're in the donut hole, if you have Medicare, there's a lot that kind of goes into it. But on average, about $10, $30, $100 a month, if it's covered, is generally the rule of thumb, versus with warfarin, as a lot of you may know, is very cheap, under $10 a month usually. So as far as can we justify that cost? Is it worth that cost? If we have a patient that has never been on an anticoagulation, the guidelines now recommend for things like atrial fibrillation or a brand new clot that we kind of go with the DOAC over warfarin due to a lot of patient convenience. So no need to test the blood with the INR, a lot less drug interactions, a lot less food interactions. They actually have a lot better, and when I say a lot better, it's somewhat significantly better than warfarin as far as bleeding reduction, like brain bleeds, things like that, general run-of-the-mill kind of non-relevant clinical bleeding and things like that. And also the patients that don't do well on warfarin, maybe it's very hard to stay in your therapeutic range, and things like that, we'll make that switch over to the DOAC medication. But they definitely are more expensive than warfarin because they're newer, and they're still the brand name, so they're going to be more expensive for at least a few more years. I think 2026 is the first time I think Eliquis comes off patent and becomes generic. They keep getting extensions every time it's up, so hopefully there's some light at the end of the tunnel. But if you have government-funded insurance like Medicare, Medicaid, you don't qualify really for any of the coupons that are available through the drug manufacturers. However, if you have private insurance, you are eligible for some of these coupons where we can get the cost down to like $10 a month or $85 a month if it's too extravagantly priced. But at the end of the day, something that I always try to echo to my patients is if you can't afford the direct oral anticoagulant, these newer medications, warfarin is not worse for you by a significant margin as if you were to not take any anticoagulant versus warfarin. If you take nothing versus warfarin, you're having a much higher risk for another clot developing. If you take a DOAC over warfarin, it's similar benefit as far as your safety goes, but where we see a little bit more of the benefit is the patient's quality of life, not having to test, not having to adjust their medications, and always be watching what you eat and things of that nature. And going forward, it's just a little bit better with the bleeding as well with the DOACs. But I guess the moral of that story is It is a lot more expensive. Talk to your doctor about different coupons you might be available for. They have drug assistance programs with all of these drug companies. But at the end of the day, if you have to be on warfarin, it shouldn't be something that is discouraging, because it's not any worse as far as preventing future blood clots from occurring. It's just a little bit of a hassle that you need to get your blood tested every so often, and that you have to kind of go through a lot of these different procedure plans that are more, but definitely reach out to your doctor to kind of help with any stresses you might have related to those.
Great. And just to, we've mentioned, you know, getting your blood tested or your INR checked a few times. Just to mention that if you are on a Dowak, that is not something that you want to get done, because you could get kind of a crazy reading, is my understanding. So that's one of the perks is you don't need these blood tests.
So with Dowaks, you just need to, it depends for the reasons. For instance, in our clinic, because of our population is oncology cancer patients, we observe whenever they come for treatments, we will see their CBCs. So like how the kidneys are working, how the liver is working, and also the platelets, because the medications, the chemos are affecting those. So we would monitor them more often. However, patients that are taking it for AFib without those issues of oncology, like oncology patients, there is no need to monitor so often. So it's perhaps, depending on the creatinine clearance, if it's great, kidneys are working great, it could be just once a year when patient need to be checked, or it's a great way also to avoid those if you are on a Dowak. The other thing is, I would like to mention that if patients have Medicare Part D, they can, the copay or the limit is $450 they spend on on all of their medications, and then they can qualify to pay less for their monthly meds, including the Dowaks. Granted, it depends how much burden of other meds there is, so then it adds up and they can end up in the donut hole. So it's really very patient specific, and they have to think about all of the benefits, but also if it happens, we have patients that we transitioned to a Dowak, and then they were, after a while, the other medications filled that pool of money available to them, and then they had to go back to Warfarin because they were no longer able to afford the Dowaks. So all of these are complex decisions between those, and patients that are on fixed incomes, it's really detrimental.
Yeah, absolutely. Now, we talk a lot about starting a Dowak or Warfarin, but Andrea, can you talk a little bit about this patient writes in they've been on Warfarin for 20 years and they're considering switching to a Dowak? What they might want to take into consideration, obviously we talked about price, but anything else if they've been on Warfarin for that long that they might want to know or think about?
Yeah, so for somebody who's been on Warfarin for a significant amount of time, I think one thing to consider is how well are you doing on the Warfarin? If you're somebody who is doing super well on Warfarin, your INR is in range every single time you test, you have a home machine, you're testing every 2 weeks, and you're kind of in the groove of it, unless you felt very strongly about wanting to change medications, I feel comfortable for those patients to continue on their Warfarin therapy if they want to. But if they feel strongly, right, and they want to move to one of the other, medications, that's absolutely fine. I think this patient had also said they had perhaps, tried one before and, had negative experience on it. And so for somebody who's trialed one of the Dowaks, well, the great news is there are actually 4 of them on the market. So we mentioned their names a couple times, but I'll just repeat them again right now. So you have, Savesa, you have Xarelto, you have Eliquis, we have Pradaxa. So just because you've tried one of those medicines and had a bad experience doesn't mean you're totally disqualified from trying any of the others. We've had several patients that have been very successful with switching to a Dowak. They tried one and had a side effect, and so we ended up trying them on another one of the agents that doesn't require testing, and they're doing very well on that medicine. So just because you had one bad trial with the Dowak doesn't mean you're disqualified from the rest. I think the question would come down to, what is the concern with the medication? Is it something where you started experiencing a side effect that was impeding, with your day-to-day, routine? Was it greatly upsetting your stomach so that, you couldn't eat? Or was it something where you just noticed a little bit more bruising or bleeding? With the bruising and bleeding concern, we know that all patients on these blood thinners or these anticoagulants could potentially, experiencing that from time to time. The way that these medicines work is it makes you a little bit more likely that when you have a cut, you're going to bleed, that when you bang your knee, you're going to get a little bit of a bruise. So if your concern on on one of these new medicines is that you've been bruising or bleeding more easily, probably just want to, take a closer look, make sure you were started on the correct dose of the medication. We would want to do something like look at your kidney function. Sometimes for patients that kidney function isn't as good as others, we can do something and reduce the dose of the Dowak so it still offers the adequate protection, but you don't experience those extra bruising and bleeding events. So I think the best thing is to do is have that discussion with your warfarin manager or with your doctor who manages your anticoagulant and say, this is what I've tried before, it didn't work, but I'm still curious about getting on warfarin. What are my options? Because there certainly are options.
Great. So you mentioned, and we've talked about this a few times now, but kidneys and creatinine clearance and that sort of stuff. One of the patients had a question about, are there any anticoagulants that do not affect/damage my kidneys? So I just want to be clear when we're talking about the importance of monitoring kidney function in these patients. Is it a result of the anticoagulants doing harm to the kidneys, or is it something else that we're looking for here?
Yeah, so I would say that's a very common kind of concern that we get from a lot of patients, even with other disease states. Every time, inherently, when you hear that we have to check the kidneys, we have to check the liver for specific medications, you think that that medication must damage them if you're checking it. The reason why we check kidney function with the Dowak medications is because that's the main route in which they're cleared from the body. So if your kidneys are not functioning normally, so with age, your kidney function declines just in general because they've been used for X amount of years and they don't regenerate. So we have to check the kidney function to see how well it's clearing the medication. So the way we check the kidney function is through a routine blood test. We see how well the kidneys are working in passing the toxic materials out of the body through the urine. And depending on the number we get, how well it's working, how quickly it passes the blood through it, we know how well it will clear the medication out of the body. So if it's not working as appropriately as it should, or as normal function, it's not clearing enough blood through it in a given minute, for instance, that medication is going to accumulate, or the levels of it will rise in the blood, and that will cause more bleeding to occur because the medication's hanging around. Similar to if you have trash at your house in your trash barrels, you don't put them out to the curb every week. The trash is going to accumulate, and there's going to be more trash, and I guess you could say the smell will get worse and worse. Just like if you have more and more of the Dowak medication, the bleeding will get worse and worse because it's circulating through the body. So the medication doesn't affect or damage your kidneys. It's your kidneys and how well they're working to get rid of the medication out of the body to make sure that it's not building up and therefore having more of an effect in the body, just like taking 2 doses at one time when you should only be taking 1 dose at one time. Similar to that thought process. And that goes with a lot of medications too. A lot of medications, some might damage certain organs, but usually it's not the medication damaging the organ, it's the organ that's not removing the medication from the body, and then that medication, whatever it does, it's doing too much of it. So in this case, the Dowak, it is a anticoagulant, and it makes it take longer for clots to form in the body, therefore bleeding can happen. So if there's too much of that, more bleeding will happen and less blood clots will occur. So I guess that's the simplest way I could put it, but the Dowak medications, Warfarin, neither of those damage the kidneys directly or do any damage to the body. It's more so of they need to get out of the body, and those are the organs that do it. So if they're not doing their job appropriately, there's going to be more effects of those medications.
Now, do all of the Dowaks and Warfarin, are they all cleared through the kidneys?
Mainly, some of them are cleared more so than others. So for instance, Eliquis, I believe, is about 62% or so off the top of my head as far as renal clearance or kidney clearance. Some of the other ones have much less clearance in the kidneys. So they all have kind of different levels, but they're all dose adjusted accordingly based on that, which they do dose finding trials to find how much it accumulates. I mean, even if your kidneys are non-existent, like you're on hemodialysis 3 times a week and you have no residual kidney function and you can't even produce urine, we still use medications like Eliquis to great success with those types of patients. So it's not an exclusion, it's just we have to adjust the dose of it accordingly. Similarly with warfarin, if you have reduced kidney function, you might be on a lower dose of warfarin, but it's going to correlate to what your INR level is to be what type of dose you should be on. So we're constantly monitoring all of that stuff, but again, they don't directly do any harm to the body.
All right, great. We talked about surgeries, but this patient writes in that their neurologist recommended Botox for headaches, and they have had 2 blood clots already, so they're a little hesitant to get these injections. Is there anticoagulation that which they are not on? Is that something they should consider, or what kind of risk for clotting are they at from getting these injections?
I think what the good news is with the Botox injection is certainly an injection, but it's not ultimately super invasive. So this is something where, we're not, having a history of a blood clot and needing a Botox and needing to undergo a Botox injection for a headache isn't something where I'd say, if you're off an anticoagulant at this time, you need to start one. I don't think that is the case. If you're on an anticoagulant and you have one of these injections, I think it's absolutely safe to continue your anticoagulant. You would just want to make sure, that if you're on warfarin, you do something like check an INR level to make sure that it's not high. If you are on a blood thinner and had something like this and your INR is high, you're going to notice a lot more bruising and potentially bleeding in the area of the site of injection. But if you're not on it and you have a history of a blood clot and you need to undergo one of these injections, absolutely, you can go ahead and get that without any worry of needing to start on a prophylactic dose of any type of blood thinner.
Okay, wonderful. When we're talking about blood clots, a lot of times we're talking about, pulmonary embolism or deep vein thrombosis. But could one of you talk a little bit about anticoagulation to treat cortical vein thrombosis or cerebral vein thrombosis?
Yeah, so cerebral venous sinus thrombosis and cortical vein thrombosis. So those are clots that are in the brain. So the cortical vein is kind of the smaller kind of vessels that lead to the sinuses of the brain, which are the large portions of the brain. Now, if you have a clot in the central venous sinus, there's a thrombus there or a blood clot that's blocking flow to the rest of your brain. Can lead to strokes, can lead to hemorrhagic type strokes, so bleeding in the brain that are damaging the brain tissue. So the gold standard for those types of clot is really warfarin and early Lovenox for those types of clots. Lovenox has very good anti-inflammatory properties. It works right away. Even in certain cases, if you have a clot in your brain and there is some bleeding, it is still recommended that Lovenox is used in those cases. Again, obviously, your doctor would be the one doing all of this stuff. It would be more so in the inpatient setting. But as far as kind of the agent of choice after hospitalization, I'd say that the guidelines for those recommend warfarin as the gold standard. I actually have 4 or 5 patients that have this type of clot. And I've looked at the studies for it. I've looked at whether we can use Dowaks in these patients. There's a good number of studies, but the data with the Dowaks is just not that robust. It's not that strong right now to suggest using a Dowak with a cerebral venous sinus thrombosis is safe and effective. It's all kind of pointing towards the positive direction, but these types of clots are super, super severe, super invasive, very detrimental if the wrong thing is done. If it's not treated early with Lovenox, can lead to a hemorrhagic stroke or can worsen brain bleeding. If it's not done appropriately, the clot can expand and you can have a massive ischemic stroke, which is killing kind of brain tissue due to lack of blood with oxygen to the brain. So I would say as far as kind of getting the benefit of being on a DOAC, you don't have to test your INR, potentially less risk of bleeding. I'd say that the benefits that the patient would see from that doesn't really outweigh the risk of not knowing how well it would work based on the age that they've been around, but also the data is not as strong there. And we know that warfarin and Lovenox work so well with this type of clot, and it's the gold standard. It's really not something that is going to, I guess, take a head of steam and go on the DOAC route because of how severe that type of clot is. So definitely warfarin with Lovenox is the drug of choice for that in the outpatient setting, and probably more frequent testing in the beginning for sure to make sure that the INR is trending in the right direction, not too fast, because we don't want to really play around with those situations. Hopefully that answers the question.
Yes, excellent. So we've got, I think, 2 or 3 more questions, and we'll talk about stopping anticoagulation and when that's appropriate. But can you, one question, and I think the root of this is because anticoagulants are thinning the blood, but do anticoagulants make your heart work harder? Was the question.
Not that I know of, no.
I'd say no, they don't. As far as thinning the blood, that's kind of like the colloquial layman's term of how an anticoagulant works. It doesn't necessarily make the blood viscosity thin or thick, just like a fluid. If it's thicker, it's harder to pour, versus if it's thin, it comes right out like flowing water. It doesn't affect that kind of chemical property of the blood in any manner. We use the term thin and thick blood when we refer to how long it takes for a clot to form. So we associate thick blood with having clots because it's all stagnant, not moving, and clots can kind of form. But that's not really what's happening. What it does is it affects certain clotting factors or proteins in the blood that trigger clots to form if they detect damage anywhere in the blood vessels. So it's affecting how well those clotting factors work more so than kind of clogging up the blood or making sure it's flowing quickly. So as far as if it makes the heart work harder, it doesn't have any effect on the contractility of the heart as some other medications do. The heart's still doing its normal thing. It doesn't have any effect on the heart at all. It just has an effect on certain proteins in the blood that can lead to clots in general, which you have normally, because if you have damage to your blood vessels, they need to be kind of clogged up. You need to make clots, because if you have a paper cut, if you cut yourself shaving, cut yourself in the kitchen, there needs to be a way for that blood to stop bleeding. You need to have certain amounts of clots. It's just how much do we affect how easy those clots are to form. Again, but that doesn't affect the viscosity or thin or thickness properties of the blood at all. It's just a term that is kind of carried weight throughout the years to describe anticoagulants. To say blood thinner is much easier to talk about than to say you have an anticoagulant medication. So I think that's where kind of the confusion may lie.
Okay, great. So this isn't a question that came in for this particular program, but we get several emails a month inquiring about at-home testing machines and how patients can get an at-home testing machine. So can one of you kind of, I know I'm sure it's very specific to different insurance and that sort of stuff, but walk through how a patient might go about starting that process?
So from what we do in our clinic, and I assume that it's universal, patient has to be on Warfarin for at least 3 months for us to actually recommend the machine. They have to be stable, and then it goes, the referral, it goes, we discuss this with the patient and explain that there are several companies. Some of them require patients to test every week. Some will stretch it to every 2 weeks. And they need to understand that it's a rental. It's based on the insurance. They will get the machine and they have to buy the strips. And that's how they test, and then they will report the results to the company, and the anticoagulation clinic will have the report, the INR reported to us. That's through the insurance. I understand that some patients will buy it by themselves, but I don't have those patients in our clinic, but I've heard of it, so I don't know if any have the experience.
So the first thing, they would have to be on anticoagulation for 3 months, and then they would contact either the prescribing physician or their anticoagulation clinic to start the paperwork with their insurance company. Is that?
Yes. So that's from my experience. That's what we do. The patient wants to start the machine, start the process, and we will send and fax the referral to the company. Then the company will contact the patient, and our role from that point on is on the background, just on the receiving end of the INRs. But the company works with the patient for how are they going to get the machine, when, the training with the nurse that is also provided, how to do it, the whole process, and how to obtain the testing strips from the company, and so on.
Okay, great. So in our last few minutes, we're going to talk quickly about stopping anticoagulation. This is an interesting question that came in over the chat. After finishing a 6-month prevention/treatment of Xarelto, can you experience withdrawal symptoms? Is that something you guys have heard of?
So as far as withdrawal symptoms go, I'm not really entirely sure what that's referring to. I know that there have been some kind of caution when stopping anticoagulation in general, whether it kind of predisposes you to or gives you an increased risk of having a clot form. I think that kind of stemmed in the studies when patients discontinued the medication that were still at risk for a clot forming, and therefore a clot might have formed in that period. Just same thing as if you stopped it for a procedure and you shouldn't have stopped it, or you should be on a different agent to bridge you through that period. But discontinuing Xarelto or any of the agents in general doesn't put you at a heightened risk or procoagulable state, I guess, to put it that way. And as far as withdrawal symptoms, there's nothing like some other medications where if you stop it, you get a headache or you get palpitations or increased blood pressure. There's nothing like that with the Dowacs or Warfarin when you stop it.
If you are feeling those things, it'd probably be something you'd want to mention to your healthcare provider.
Absolutely. Anytime you'd feel any type of symptom like that, you'd want to make sure your doctor's aware, but it's not necessarily from withdrawing from the Dowak medication. There's no tapering off or anything. When you're done, you're done. And when you're done, it's because you're no longer at risk for another clot forming, or your risk of bleeding is more than your risk of clotting. So that decision will be made hand in hand with you and your doctor as far as when the appropriate time to stop would be. And you would just not take the next dose and just go on.
Okay. Could it just briefly, one of you just elaborate on that decision to stop taking an anticoagulant, and typically, how that decision comes about? Is there certain periods of time that patients, typically have these conversations, or is it just kind of an ongoing conversation with your healthcare provider? How to kind of start this, discussion with them? Or if it's something that maybe they can never have that discussion, they're on an anticoagulant, for the rest of their life.
So some patients, for instance, the patients with AFib, I think they will be most likely for the rest of their lives if they don't have the procedure to repair or ablation, and then they may stop with. But I just wanted to mention in the oncology clinic, patients that are we will stop anticoagulation. For instance, patients that there is no longer risk. They had the DVT because of the hypercoagulable state that is caused by cancer. Then patient go through treatments, and they will be then after 6 months on a lowered dose of the Dowak, like Eliquis, and for secondary VTE prophylaxis. But then after the cancer is no longer an issue and the doctor does the scans and there's no residual, then it may be that the decision will be that the anticoagulation is stopped. That's from my experience. Andrea?
Yeah, absolutely. I can speak to that a little bit more as well. We tend to manage, we actually send all of our oncology patients to the Dana-Farber Anticoag Clinic. And then the rest of the buckets of, our patients are really about 50% of our patients at BWH Anticoag are atrial fibrillation. We've got another portion that have mechanical valves, and we have another portion that don't have either one of those things. They just have a history of having a blood clots. So the root of the kind of what we need to answer is, one, why is the patient on an anticoagulant? And two, is that risk of having a blood clot still present? So for the AFib patient, essentially what's required them to be on an anticoagulant is the fact that their heart is not in normal rhythm. And when that happens, you can have blood pooling in your heart chambers, which could potentially cause, a thrombus to form. And, it could travel to your brain and cause something like a stroke. So that's why we have patients that have atrial fibrillation on warfarin. So for as long as somebody is experiencing atrial fibrillation, there's a need to be on these blood thinners. However, if the patient goes through an intervention like a cardioversion, an ablation, and we're able to restore your heart back to a normal rhythm, a lot of times we can discontinue anticoagulation, after that has happened. For the patient that has a heart valve, the question is, what type of heart valve do you have? Is it a metal heart valve, or is a heart valve that's made out of, a cow or a pig tissue? If it's something that's made out of metal, that's a foreign object that's in your body, and it's going to be a lot more prone to having blood clots stick to it because that metal will get sticky. So for people with metal heart valve replacements, we want you on warfarin for your lifetime. If you have a tissue valve, though, after about 90 days after surgery, we can discontinue the anticoagulation. So we leave it on board initially, but then, you know, after that risk minimizes, you don't have a piece of metal, it's tissue, so your body is able to recognize it as less of a foreign object. So for people with a tissue valve heart replacement, realistically, you know, 3 months and you're done, hopefully. For patients that have a history of blood clot, the question is this: is it your first blood clot? A lot of times if it's your first blood clot and it's provoked, meaning we know the reason, like you just had you know, a major orthopedic surgery like a hip or a knee replacement, in that setting, we can comfortably stop anticoagulation after 3 months. But if you're somebody that has multiple blood clots in your history, many through the years, or you have a blood clots, but we can't get to the bottom of knowing why you're having them, in those situations, we tend to keep people on lifelong. So I'd say the reason why you're on warfarin matters, and then also, you know, just kind of putting in some specific, you know, patient considerations there as well.
Okay, wonderful. Well, I know before we start, I promised you guys this would not go past 8 o'clock. It is 8:02, so I apologize. But this was so great. Thank you guys all for taking your time this evening and, you know, really doing such a thorough job answering these questions. We really appreciate it. Like I said before, we did record this evening, so we will have it posted on the NATF website. So if you missed anything, you know, you can certainly go back and reference that. And we will meet again next quarter. This is a quarterly series that we do. So Themio, Beata, Andrea, thank you so much. This was really wonderful. And I hope you guys all have a great evening.
Thank you for having us.
Thank you for having us. Good night.
Thank you so much.
Thank you. Bye-bye.
Bye, everyone.
Bye.